Hi, this is Dr. Farley, and in this video, I want to go over with you some of the concepts on the neuroanatomy of memory, right? So, how do we get memories? How do we um, keep our memory? How do we not get dementia, Alzheimer's, and what over a time frame can be done? So, what we need to understand is everything comes down to proper function. I just had a woman who reached out about her mother that had memory problems and was asking, if you're suggesting me, Dr. Farley, that you could help with memory, dementia, Alzheimer's type patients, why isn't everyone doing it? Well, I hear that a lot about a lot of different things. So you need to pull back and view a person or a doctor's philosophy on health. And my philosophy is very simple. We try to measure, find functional deficits inside the person with the memory issue, and know what those gears are, and then go to my toolbox to say, what would we do to influence those mechanisms in a right direction? I think the research that I heard recently is that there's up to 15,000 papers published on dementia and memory, and yet none of the information is really trickling down into the treatment of patients. So although there's no guarantee of anything. There's no guarantee of a surgery. There's no guarantee of a drug, or that the drug won't kill you. There's no guarantee of anything. What there is a guarantee of is that if you look at problems from a functional point of view, a physiology point of view, you at least have some understanding as to what's not working properly. Most of these diseases, including dementia and Alzheimer's, are not genetic, maybe 5% at most. I read this over and over again. So these things are not genetic. So if you have a parent with dementia, it doesn't mean that genetically you're definitely going to get it, but you should look into it because there could be other mechanisms that would increase your risk, and you would like to take a look now at what is my risk moving forward, and that would be to look at how your function is now, and do you have certain mechanisms and through certain tests to determine that your level of function is already not moving in the right direction. So basically, when I reviewed memory and the neuroanatomy of memory, the entire brain is involved. Encoding, which is the ability to take the short term and turning it into long term, is done in the temporal lobe, an area called the hippocampus. The hippocampus is also a major player in slowing down or breaking your stress response. So stress and stress hormones over time can be one of the mechanisms that can overload and damage the hippocampus. And then we run an excessive stress response, and we hardwire it into our brains and our bodies more and more and more and more and more. And then also at the same time frame, we start to notice that we are damaging our memory. So as stress goes up, memory can go down through that mechanism. Another key area is the cerebellum. The cerebellum is termed the little brain. It's the back and bottom portion of the brain. So when you're looking at the brain itself, this is me looking forward like this, turning me up. This is the cerebellum here. And the cerebellum really controls and coordinates the entire brain. It is essential that the cerebellum be working properly. So this cerebellum runs this cortex, this cerebellum runs this cortex, and there are tests that you can do to see, hey, is my cerebellum working properly or not? And to me, that is a starting point, because if the cerebellum is off, the whole brain has no ability to work optimally, because the tone and the general functional level of the cerebellum sets the tone and the general functional level of the rest of the entire brain. We also know that the amygdala is involved, and the amygdala is part of the emotions. So the more emotional an event is, many times the more vivid the memory is. So over a time frame, that's how emotions can start to impact our memories. And if we have something that's extremely emotional, normally it's going to have a much bigger ability to have a bigger memory. The basal ganglia and motor is involved also, and the basal ganglia is also involved with many other motor problems like Parkinson's, dystonia, Parkinsonian, multiple systems atrophy. These are all things that are under like the Parkinson's umbrella. And what we know is that Parkinson's disease involves both motor and cognitive impairment. Many of the people that are coming to me for Parkinson's or an assessment of Parkinson's have never had their cognitive abilities tested. We do this in a very detailed analysis. We do extremely detailed testing. We do 63 functional tests in our Super 7 Plus evaluation. And a nice portion of those are cognitive assessments. We use some of the most detailed cognitive assessments in the world, and then we can look at that to see if that's a problem. The frontal lobe is also involved. The frontal lobe is mainly your executive motor functions as well as your movement ability. And for many people, many things can cause breakdown of the frontal lobe, and then over a time frame that would impact memory. Your temporal lobe is involved. Temporal lobe is also involved with hearing, also involved with emotions, the hippocampus again, and the temporal lobe also is involved with disturbances of auditory sensation. So another term for disturbances of auditory sensation is called tinnitus. So people that are having issues with tinnitus is really not an ear problem. It's really a brain problem. It has multiple mechanisms creating it, but should be addressed to see if it can be influenced and changed. The parietal lobe is basically this part back in here, and the parietal lobe is where all your sensations reach consciousness, and also is what gives you your ability to have the perception of yourself and the world around you. Coming into that parietal lobe. So if there's abnormal sensory input from the body, polluting in a sense the brain, the cerebellum doesn't work, our parietal lobe doesn't work, our perception, our sensations can be off, which can be abnormal sensations in pain, in numbness and tingling, in bugs crawling on you, all kinds of odd sensations that people complain of, as well as an inability to perceive myself and my environment properly, which could turn into psychological problems, social problems, all kinds of issues. The occipital lobe mainly is involved with your vision, but also does have a role in memory as well. And again, we want to go back to the idea that Parkinson's disease does many times come along with a memory component. So patients will come in, or their spouse will come in, and they'll say, yeah, they're noticing that they're having memory issues as well. They can't, they just kind of seem out of it. They can't put things together. And over a time frame, that's a combination of motor and memory. And so both of those areas should be tested and looked at. So most of the time when I see a patient coming from the typical neurologist, maybe there was a testing done, maybe there was no testing done. They may have you walk and they come back and they say, hey, we think that you have Parkinson's, and then here's the drug, and that's as in-depth as it goes. Again, if the drug influences the symptoms in a positive direction, you may consider using it even though there's massive side effects of it. If the drug does not influence the symptoms, then you may come to the conclusion, and I would also come to the conclusion, that I'm not going to take it because it does have long-term side effects. So I hope you found this interesting on the neuroanatomy of memory. And again, there needs to be a very detailed, individualized look at a person with memory issues to try to come up with, first of all, can they be helped? Would they qualify? And second of all, what would that plan be? And if anyone is talking about a protocol or specific, magic bullets like things called cures, which I'm not a fan of. Cures are a myth. They don't exist. A cure basically means to restore function. So we are not going to find cures for diseases. What we can do, though, is identify what's not functioning properly in our physiology, understanding all of the connections of this physiology, and then go to understanding what mechanisms of action we can influence and how would we do that. And this is the best that we can do to try to shift someone to a higher level of function and to some stability. And if the person is going to decline, keep it at the slowest rate possible. Thanks. Have a great day. Any questions, as always, please let us know. God bless you. God bless your family. And God bless the United States.